In this module, I'm going to introduce a few new terms that you'll need in order to classify bony types of defects. The gingival sulcus is the shallow crevice or space around the tooth bounded by the surface of the tooth on one side and the epithelium lining the free gingival margin of the gingiva on the opposite side. It is V-shaped and barely permits the entrance of a periodontal probe. In clinically healthy gingiva, the sulcus can range from 0 to 3 millimeters in depth. Here in these two photomicrographs, you can see we have healthy connective tissue, epithelium, and our tooth surface. The alveolar bone is here. This area, as well as another cross-sectional view where we're looking at the epithelium and the connective tissue, the junctional epithelium, and the tooth, appears free of inflammation and inflammatory cells, and there is no attachment loss. In contrast, as plaque accumulates, there are clinical and histologic changes which take place. In contrast to the previous slide, we can see distinct changes in the epithelium and the connective tissue in this slide. This is an H&E section where the epithelium demonstrates downgrowth of the reedy pegs, and in addition to these reedy pegs becoming more predominant, we have an increase in inflammatory cells within the connective tissue. Deepening of the gingival sulcus may occur as a result of a coronal movement of the gingival margin, apical displacement of the actual epithelial attachment, or a combination of the two processes. A superbony defect is a defect which occurs when the bottom of the periodontal pocket is coronal to the underlying bone. In this instance, you can see here's our epithelium, our alveolar bone, and our connective tissue. Even though there has been plaque accumulation on the enamel and dentin surface, there has not been much migration, and as a result, we have this suprabony pocket. This can occur with horizontal bone loss, and typically the transeptal fibers are intact interproximally. Contrast the suprabony defect to our next defect, termed an intrabony and sometimes referred to as an infrabony defect. Here, the base of the defect is going to be apical to the crest of the alveolar bone. Again, in our diagram, you can see our root surface and dentin have plaque accumulation. There has been downgrowth of the epithelium and loss of the alveolar bone as a result of the disease process. Here, typically, the pattern of bone destruction is vertical, and interproximally, the transeptal fibers are arranged obliquely because of this vertical bone loss. We're going to next look at a radiograph of a mandibular canine and premolar area, and we're going to compare and contrast a suprabony to an intrabony defect. Here in this radiograph of the mandibular teeth, we can see these two distinct processes occurring. On the premolar, we have a vertical loss of bone representing an intrabony defect. On the premolar that is immediately mesial to it, it appears that we have had some horizontal bone loss, calculus deposits on the root. However, there has been no vertical bone loss. This represents a suprabony defect. When we look at this histologically in our middle slide, it becomes even more apparent. Here again, on the mesial of the premolar, you can see our vertical bone loss and a resulting downgrowth of the epithelium. This is our intrabony defect. Whereas on the tooth that's immediately mesial, we can see that there has not been this vertical bone loss on the distal aspect of this tooth, representing a suprabony defect. At even higher power, you can see this more dramatically. This is the alveolar bone. Our transeptal fibers are present in this region. We have some connective tissue in our epithelium. Once again, there's been a vertical loss of alveolar bone, thus representing an intrabony defect.